Okay, time's up. Dear Chairman, time is up.
Okay, so we can start.
Please. Yeah.
Yep. Are you gonna start the first slide? Good afternoon, everybody. Thanks for being here today. So we are having this APSC Cloud Forum, the of cardiovascular diseases series, and we're gonna talk about implementing recent innovative technologies in cardiac arrhythmia treatment in 2025, skills and tricks. And let me cite the annotation. So, been technological innovations in cardiac arrhythmia therapy has reshaped the decision-making and therapeutic approach in contemporary cardiac electrophysiology. Wearable devices in atrial fibrillation screening and therapeutic guidance, new pulse field energy in catheter ablation of various atrial fibrillation, LAA occluder for stroke prevention of high-risk atrial fibrillation, new conduction system pacing or LBB pacing for HFrEF, as well as leadless pacemaker in symptomatic AV block or sick sinus syndrome are the intriguing topics to be presented and tracked in today's webinar. So I will be your chairperson today, and together with me, we have a co-chairperson as well. My co-chairperson is Dr. Xie, and he's the professor of medicine, School of Medicine, College of Medicine, Taipei University. He's also the chief of cardiovascular center of Wanfang Hospital in Taipei University Hospital. So let me cite the disclaimer as well. The content of this webinar is copyrighted by the APSC and should not be distributed without the prior permission of the APSC. The views and opinions expressed in the webinar are those of the faculty members and do not necessarily represent those of the APSC. So some of the housekeeping matters. The live streaming content of this webinar will be made available via APSC Cloud, APSC Facebook, and APSC YouTube page. So let's get started with the first talk of the day. It gives me great pleasure to introduce Dr. Francis Lim from the Department of Cardiology in Brunei, Raja Isteri Pengiran Anak Saliha Hospital, Brunei. He's going to talk about atrial fibrillation screening by wearable devices in guiding therapeutic approach. Who, when, and how? Dr. Francis, please. Sorry, Dr. Francis, you're muted.
Can you hear me now? Sorry.
Yes, I can hear you.
Okay, can you see my screen?
Yes.
Yeah, okay. Okay, hello everyone. I'll start again. My name is Francis. I'm from Brunei. This is my hospital, Ripas Hospital. And thank you to APSC, the chairperson, Dr. Tan and Dr. C. So today I have the pleasure of talking about atrial fibrillation, screening by wearable device and guiding therapeutic approach, who, when, and how. So just for this overview of the top, with introduction, why screening matters, and a bit on some of the wearable technologies available, and then who, when, and how we should be, or at least should be screening, and just some cases, and then lastly on some of the challenges and hopefully future directions of wearable technology for screening in AF. So we know atrial fibrillation is a growing global burden. We know it increases with age, and at least in the USA, there's 6 to 12 million people with AF and expected to double in 2030. And we know AF accounts for at least a third of strokes, and up to 30 to 40% of AF is of asymptomatic you can call it silent or subclinical. And not uncommonly, the first sign we know these people have AF is they present with a stroke, and can be quite devastating. So one of the things is you can identify AF, atrial fibrillation, before patients have a stroke, and we can hopefully try and prevent them from getting a stroke. And we know that nowadays we have all this wearable technology, and it can help expand screening beyond clinical settings, such as when they come to hospital. So this is a slide from the AHA. So usually we see patients when they come to hospital or clinics, they have symptoms. We do an ECG or Holter, for example, which confirms AF, and we start treatment. Right? And we know this is actually tip of the iceberg, that a lot of patients do not have symptoms, and we're not aware until they have a stroke. So ideally, we can identify them somehow, whether it's incidental finding, implanted device, wearable devices, or sometimes they end up with a stroke, and then we have to look for them, right? Because it's a proximal atrial fibrillation. Of course, there are some things we have to consider when we screen people without symptomatic AF, and we'll talk a bit more about this later. So these are some of the devices out there, different manufacturers. There's lots of different smartwatches and other types of wearables which talk about. And some of the benefits is we can do continuous monitoring. We can also do intermittent monitoring depending on what we want to do. But they're hopefully quite user-friendly, quite easily accessible, mostly. And nowadays they are quite sensitive and specific, and potentially able to reduce stroke. Okay, so then there are different ways of looking for AF. Of course, the watches, they use PPG, and they have sort of single or even up to 3-lead ECG, which patients use their hands. And then we have patches where we can wear up to few days, up to a week, sometimes months. And then, of course, blood pressure monitors can detect irregular heartbeats, and we have implantable devices, and even with the implantable device monitoring, and then we have patients with devices for other reasons, pacemakers, ICD, which can also help. And they all have variable specificity and sensitivity, but they are quite good nowadays. Of course, with the ECG ones, a bit better, but they're all reasonably quite good, and some good trials of these. But there are also some limitations, and of course, these smartwatches are good, but of course, we have alerts. Then they can given some false positive results. They can also some patients provoke anxiety. They just keep looking at the smartwatches. And patches are quite good. I like to use them in our setting, but we have found that some patients do get skin irritation with the blue and again, but these also depend on the manufacturer, so you have to so proprietary, and you have to pay for them. So I'm not familiar with clothing ones, but there are out there, but they can be quite bulky, especially to wear them. Okay, so these are some of the advantages, disadvantages. And now coming to who should we screen. So ideally, we probably don't want to screen everyone. We want to screen people which we can get the highest yield. And if we detect AF, we treat the atrial fibrillation, such as anticoagulation, we reduce that stroke. They show the most benefit in anticoagulation. Right? So these are people who are at least 65 years old, people with higher Charles-Plus score, and with heart failure, diabetes, vascular disease, with cardiovascular risk factors, and patients with embolic stroke of undetermined source tend to be younger. And they may have proximal AF, which may be trigger, and maybe sinus releases. And we can consider younger people, such as patients above 65 to 64 with some risk factors, as patients during specific treatments such as antiarrhythmics, for example, post-treatment ablation, and perioperatively as patients with post-cardiac surgery, which we may not want to give them long-term anticoagulation, but we may want to they may be at higher risk of different AF and stroke in future. We may want to have a longer term monitoring. And this on the right is the ESC guidelines on this, but they didn't codify as such, but papers talk about when we should screen people. So we have the opportunistic screening. So every time there's a healthcare encounter, whether it's primary healthcare, hospital setting, when they come to hospital, we feel the pulse, right? We check the blood pressure, maybe an ECG, and then we can take the opportunity to also ask them, do they have a smartwatch? Do they have any notifications, for example? Well, we can try systematic screening, so screening everyone, such as patients who are above 55 to 64 with risk factors. And then we, of course, should seriously consider screening anyone who's at an embolic stroke of unknown source. Okay? And potentially, again, even younger patients with cardiovascular risk factors. And at least nowadays in Brunei, we see a lot of younger people with strokes, less than 50, even people with heart failure and MIs. And then we can consider what we call the consumer-led. So it's patient who are very keen to wearing these smartwatches, for example, or even buying these ECG, single or 3 ECG monitors. Now we see a lot of people wearing smartphone, even smartwatches, even smartphones. You can do that. Of course, these are ideal for people who are more tech engaged. And then, of course, we see them if they detect something, whether the symptoms or ECG abnormality. Okay, and how? So, how should we screen these people? And again, we have a lot. When we see the patients, we can consider whether they do PPG. They have smartwatches, which we can just ask them to use smartwatches. And patients, which we can consider patch-based, especially if we want the longer-term monitoring. And then we have hybrid, and some places are wood. We've asked, especially post AF ablation, we've asked patients to buy their own cardiac band life core. Okay, and we've done some AF screening in Brunei, which we have gone out in the community and screened people with the life core ones. And of course, with smartwatches, you can wear them all the time. You can wear them for other things, but we get a few false positives, some alert fatigue. With the hybrid medical wearables, which we find they're quite good, because then they can have some cost. And then we have the continuous ECG monitoring. This is just a combination of medical wearables and consumer grade, which have been FDA cleared and have good study, such as Apple watches nowadays, the life core. And then we also sometimes use implantable recorders. They are, of course, probably the best, but they are costly and they are invasive, and not all patients are very keen on them. The main thing is, even if patients agreeable and we screen them, the main thing is we need to do an ECG confirmation, right? The ECG that we are confident shows atrial fibrillation. So the pathway is that even if there's an alert, we need to review the patients with within clinic with an ECG or looking at tracing somehow. And then we need to see the patient and then discuss with the patient whether one of the main things is we want to reduce risk of stroke. So we need to consider an anticoagulation. Nowadays we are using more DOACs. But of course, we have to manage the symptoms. We have to consider their atrial fibrillation rate, and we also have to consider whether they should be for ablation. So these are some more patient education and shared decision making. This again is a paper from HA. So to consider the benefits of stroke prevention and balance against the harm of anticoagulation, which is really bleeding. Okay. But of course, we know there are some. It's not just anticoagulating, because we know in some of the recent device detected AF, the NOAA AFNet and Arrhythmia, because if we anticoagulate patients, we reduce their stroke of risk, but then increase the risk of bleeding. All right, so whether the benefits and the risk, they may end up with the net sort of even with, right? So to speak. Then we have to consider, do we just, when should we, what is significance? Is it a few minutes, few hours, and how long and how frequent? So such the AF burden. So when do we start anticoagulation? So it's not just a binary diagnosis, but more of a risk continuum, mainly based on the AF overall risk burden. And other things we should consider is, of course, what the AF rate is, whether we need to start treatment to lower the AF rate. We need to consider when we should ablate these people. And then we also need to consider about addressing the cardiovascular risk, blood pressure control, diabetes control, weight loss, and then we need to assess whether they've got sleep apnea. And we know that there's some studies showing that long-term after AF ablation, there remains sinus, where they may not necessarily always need long-term anticoagulation, which is what we've been doing currently. And so some of the challenges and unanswered questions for screening for AF. Okay, when is it clinical significant? What are significance of some briefer, rarer episodes, or if they have a lot of short episodes of AF? Because we do get some false positive, and then we think about workflow, and then because this will impact not just on doctors, technicians, technologists, and then responsibility for after hours. Our alert currently for some of our devices is within hours, after hours with the on-call doctor, and so that adds a burden for them. And we think of things like data privacy, security, and access and equity issues, right? Because for some of the wearables, consumer-led, we know not everyone can afford to pay for these things. And then, of course, we think of cost effectiveness and reimbursed model in certain countries and healthcare systems. So these are just from on the ESC papers, right? So these are some things we consider: prevalence, undiagnosed, which population. I think we still haven't quite decided on who are and when we should screen them. So anyway, back to the sort of examples, case studies. Case one is a 68-year-old gentleman, hypertension, overall his chest bus score is 3. He buys a smartwatch because he wants to exercise, get fit, but he gets his alerts from his smartwatch says that he's got irregular heart rhythm. He's asymptomatic. He goes to see his doctor, who does a patch which he can wear for so 30 days in this case, which confirms that he has episode of proximal AF lasting 3 to 6 hours. And in this case, we started on anticoagulation. In this case, ideally, hopefully, can help prevent, reduce risk of stroke. Whereas in the case 2, we have a 58-year-old lady who had a cryptogenic stroke 3 months ago with a chest bus score of 4. A 30-day monitor is negative, so we've never actually captured an arrhythmia because patient is understandably a bit frustrated with repeated monitorings. We haven't found anything, so we eventually put in an INR, which detected a 22-hour episode of silent AF. In this case, we started a DOAC, so hopefully in this potentially her AF, her stroke was due to an episode of previously undiagnosed atrial fibrillation, and starting DOAC can help prevent, reduce the risk of stroke. So these cases illustrate that in opportunistic screening or consumer tech, we can potentially help start anticoagulation and reduce risk of stroke. And second one is to diagnose cause of stroke, and in both pathways, they are now enabled by some of the technologies we have available. So the future is potentially, with AI nowadays, they can help predict AF and ECGs, personalized threshold, depending on the risk profile. And ideally, this can integrate with our EMR right? So we can now watch it, assess this remotely. Ideally, we should have a closed loop system where the wearable detects and expands early detection. One of the clinicians are informed, and then we can assess the risk and then start appropriate therapy. And then potentially even using continuous BP monitoring, because there's also risk factor for stroke and risk factor for AF development. And then we have to consider how we do, integrate into the more population and assess for everyone. So in conclusion, we know AF is common and can be silent and dangerous, so proactive screening is an important stroke prevention strategy. And who we should screen is probably people above age 65 and high stroke risk with potentially CHF score is 2 or more. And we have to consider opportunistic, systematic approaches to screening based on the individual risk. And then ideally, we could consider using DPG, so smartwatches for broad screening, and then more targeted ECG-enabled devices for confirmation. We need to confirm with some form of ECG and timely anticoagulation. Okay, but we also have to consider workflow integration because it's different healthcare system, countries, different ways of integrating this. And this will be my last slide. So this is just to show that this is from a paper from a few years ago. Different, even now, still different countries have different ways of recommendations for AF screening. So in this Asia, based from the APHRS, they recommend opportunistic screening for people with 65 years above and 75 for systematic, similar to the European Society and Canadian and Australia, New Zealand, whereas American and UK at that point at least did not recommend national screening for atrial fibrillation. And with that, I thank you. Okay.
Yep. So thank you, Dr. Francis Lim, for your very insightful talk. We do have some time for questions. See what questions do we have? Yeah,
Lim,
Dr.
I have one question for you. If a patient with a CHFREF score of 2 and went to your clinic and show the Apple Watch with a duration of about 20 seconds. So how will you do in your clinic and will you give anticoagulant for the patient?
Yes, thank you. So I think Apple Watch, I find that they are quite accurate nowadays, and we do have patients coming with us with the PDF of this for single lead. I think personally, 20 seconds. I think this is what we call a joint decision. So we've discussed the patient, the pros and cons. What we think, the CHFrEF score 2 potentially. I probably would want to integrate if the patient is agreeable. If the patient is not keen, then we might discuss longer term monitoring. And how we monitor it will partly depend on, the AF burden and what patient prefers. Yeah. So I think it depends. Although there's probably a lower threshold, and if the patient's agreeable, I sometimes would consider anticoagulation. Yes.
Thank you, Dr. Xie, for your question. I actually have something quite similar in terms of what I want to ask. So similar to the patient that Dr. Xie was saying, but if let's say the CHFrEF 2 is a prior stroke, and the AF screening has been done and nothing was shown, and subsequently he has a wearable like a watch PPG, not reaching that the 30 seconds diagnosis is just very short runs of AF. What would be your management approach?
Okay, thank you. So again, quite similar. Although if the patient has a stroke, probably the threshold will be a bit lower. So I'll be very keen to start anticoagulation. But again, it depends on the patient. We will again discuss with the patient again, explain the uncertainties of starting anticoagulation in such cases. Depends, but if the patient is agreeable and keen, I personally probably will be happy to start. Again, we might consider longer term monitoring depending on how the patient feels. So I think this is kind of the joint and shared care decision process.
Yeah, thanks,
I-
Dr. Francis. Yep,
I
another
have one
question.
more question regarding the subclinical AF detected by device. Now, there are some RCT showing the anticoagulation is not effective, but some dangerous to such patient. So the guideline recommended the patient have higher CHABA score, such as higher than CHABA score of 4, then will prescribe the anticoagulation for subclinical AF. How about your opinion?
Yeah, so we also have this debate all the time about when we should start anticoagulation, and I think at least in our center, there's still we leave it to for the individual doctors to discuss with the patient, and then we of course explain to the patient the uncertainties. But the higher the CHATSPA score, like is similar to what you're saying, the lower the threshold we would recommend. And a lot of times patients kind of also ask us what do we recommend, because they especially if there are symptoms like the subclinical. Again, it's not a straightforward answer. It all depends. Again, it's a shared care and discussing with the patient and what the patient feel about anticoagulation. Yes, and the bleeding risk, of course. Yes.
Okay, thank you.
Yep. Okay. Thanks for all the questions and very insightful answers from Dr. Francis. In the interest of time, let's move on to the next talk by Dr. Martha. So it's my privilege to introduce Dr. Martha from UAE. He's an EP consultant at Rashid Hospital, Dubai, UAE. And her topic given was full application of pulse field ablation in paroxysmal and persistent atrial fibrillation intervention, skills and tricks. Dr. Martha, please.
Thank you so much for the introduction. Good morning, everyone. It's a pleasure to participate in this webinar. I will share my screen now. Okay. Okay. Sorry. All right. So this is the sorry for that. This is the agenda for my talk. First of all, I will talk about basic biophysics of PFA, advantages and disadvantages, potential complications, applicability of PFA to paroxysmal and persistent AF, and in the end, I will talk about some tips and tricks. Sorry for my voice because I have a heavy cold. Pulse field ablation means the application of high voltage, short duration electrical pulses that can change the polarity of the phospholipid membrane of the cell, opening pores in the membrane. This is also called electroporation, and electroporation can be reversible. For example, has been used, this is nothing new, has been used to for the transfection of DNA or drugs or chemicals into eukaryotic cells without killing them. Or it can be irreversible electroporation, for example, for the treatment of tumors, and in more recently, in our case, for the treatment of cardiac arrhythmias. It's a non-thermal therapy. This means that there is no injury to the endocardial tissue, unlike the thermal therapies. And it's selective for the myocytes because the myocytes are more sensitive or have lower energy threshold to induce apoptosis than other tissues. There are several variables that can be adjusted for PFA. We can adjust the pulse duration, monophasic or biphasic pulses, the voltage amplitude, delay between pulses, number of pulses per burst. If it's RP gated or asynchronous, the interelectrode distance, the more distance, the bigger the lesion. And also the orientation of the fiber relative to the electric field influences in the current flow. The longitudinal fibers or the parallel fibers have less resistance to the current flow, so it will there will be a bigger lesion in the parallel fibers than compared to the perpendicular fibers. But I have to say, sorry, I have to say that each PFA platform has its own recipe. We don't have the control of these variables. And the only thing we can, we can do is to press the button and apply the energy. The only thing we have control on is the contact. And contact matters. Contact is important. It's important because the current received by the tissue is proportional to the distance from the source. If we don't have a good contact, the tissue will receive less energy, and the energy will be dissipated into the blood pool, giving more hemolysis. Advantages of PFA compared to the old techniques, the thermal techniques, and I will focus on the single shot catheters. PFA is a faster procedure. It's a non-operator dependent, and the learning curve is very fast, as we have observed in the Euphoria trial. Now that we have the 3D integration, we can do a procedure with minimal fluoroscopy or zero fluoroscopy if we use, for example, eyes for the transeptal puncture. There is no injury of surrounding structures. As I said, is specific for the myocytes, is selective. So there is no phrenic nerve palsy, at least persistent, no esophageal injury, and no PV stenosis described. There is no risk of perforation directly from the applications, unlike the radio frequency. There is less atrial inflammation post-procedure, and this links to less risk of stroke because there is no damage of the endothelium, there is no damage of the microvasculature, and less local inflammation, less char formation. And this also links to a reduced risk of stiff LA syndrome. Disadvantages are very few. For example, one disadvantage can be that each platform cannot be compared to the other one, so we cannot take the outcomes from the studies done with one platform and take them as valid to use another company. We don't know yet the outcomes in the long term, at least beyond 1 year, because of the limited number of studies. And of course, one of the limitations can be the cost of although hopefully in the future the cost will be reduced. The rate of complications in general is very low. It's around 2% or less. And the most frequent complication is the cardiac tamponade. In this case, the cardiac tamponade is related to the manipulation of the catheter. And the other most frequent complication is the vascular injury. These are the single-shot catheters available in the market, at least the main available. And as you can see, they have different shapes. Most of them have are over the wire catheters, except the variables. And for example, for the FARAWAVE, you can play with different shapes. You can have a flower shape or basket shape, and you can also play with the diameter of the basket. For the variables, you can also modify the diameter of the loop, and the other two are kind of fixed shapes. Each company has looked individually into the profile, the safety profile, and the effectiveness. Regarding the primary effectiveness endpoints, usually they are freedom of atrial arrhythmias, redo ablations, cardioversions, and antiarrhythmic drugs. And the effectiveness for these platforms varies between 70% and 83.5%. For primary safety events, the rates are between 0.7 and 2.9%. And regarding the applicability of PFA to the PV isolation only for the treatment of paroxysmal AF, the study with the biggest number of patients is the Manifest, which included 17,000 patients, more than 17,000 patients. This was done with the FARAWAVE catheter, and this was a study focused on the safety of PFA mainly. Majority of the patients were paroxysmal, and 50-50 were done with general anesthesia or deep sedation. This is the rate of major adverse events. There were no esophageal events, no PV stenosis, no persistent phrenic nerve injury. And as I mentioned before, the most frequent safety event was pericardial tamponade, which I have to say significantly improved in the second phase of the study. This means that the learning curve helped to reduce this complication. And the other most common complication is the vascular injury, but this also was significantly reduced by the use of vascular ultrasound. Strokes happened in 22 patients in this study. And of these 22 patients, 9 strokes were considered preventable. 4 cases were due to catheter exchange sheath management. It's very important during the procedure, if we have to exchange the catheter, to do a good aspiration of the steerable sheath with a 20 cc syringe. 2 cases were attributed to a low ACT. For PFA procedures, the ACT should be between at least minimum 300, between 300 to 350. 2 cases were attributed to interruption of the anticoagulation, and 1 case due to uncontrolled hypertension. The coronary spasm is a very famous complication, but I have to say in this large study, the rate of coronary spasm was very, very low. It was 0.14%, and the majority of the cases were due to the applications given in out of label positions. For example, the mitral isthmus or CTI. There were 3 cases reported as generalized spasm, This was lower than, for example, using radio frequency or the cryo balloon. And this is thought to happen due to an activation, massive activation of the sympathetic system. If we look into the efficacy of PVI with PFA, we have to go through the ADVENT trial. This is a randomized trial that randomized patients to PFA versus thermal ablation in a one-to-one fashion. And it was designed for a non-inferiority endpoint. And the primary efficacy endpoint was freedom of atrial arrhythmias, cardioversion, and no class 1 or 3 antiarrhythmic drug use. And the non-inferiority endpoint was met at 1 year with 73.3 effectiveness for PFA versus 71.3% for thermal ablation. Very similar results. Moving towards persistent AF, we have a recent publication using, again, the farawave catheter for persistent AF, doing PVI plus posterior wall ablation, leaving the CTI at the operator discretion to be done with a focal catheter for PFA. Another interesting thing about this study is that the monitoring was done with an implantable loop recorder. 255 patients were included in the study, and the follow-up was 12 months. The primary effectiveness endpoint was a composite of acute success of the procedure, freedom of atrial arrhythmias after a blanking period of 3 months, freedom of reablations, cardioversions, and freedom of escalating doses of antiarrhythmic drugs or adding new drugs. The event rate, the safety event rate was 2.4% at 3 months. There were no reports of esophageal fistula, PV stenosis, or phrenic nerve palsy at 12 months. And the primary effectiveness event-free rate was 73.4%. This is quite a good number considering we are talking about persistent AF, and we are monitoring the real burden with an implantable loop recorder. If we are less strict and we just consider the symptomatic recurrences only, the number increases to 81% of freedom of symptomatic recurrences, which is also a good result. There are other locations where we can apply the PFA, although I will highlight and I will emphasize that this is completely off-label. In the first picture, you have an example of application in the superior vena cava. More specifically, this was done with the basket shape of the farawave. In the second picture, you can see CTI applications. We have to be aware, very aware of the coronary spasm and give a nitroglycerin, as I will tell you later. In the third picture, you have an example of an atrial flutter mapped with the same catheter and ablated with the same catheter. This was an anteroseptal atrial flutter. And in the fourth picture, you have an example of applications in the mitral isthmus. I wanted to share the protocol that was used for the Advantage AF study. When they did CTI applications, they used 3 milligrams bolus of nitroglycerin 1 minute before starting the applications, and these bolus could be repeated after every 2 minutes with a second bolus or even a third bolus if needed. I have to say, in my experience, with one bolus, one initial bolus is enough. I use 2 to 3 milligrams of nitroglycerin, and this was also the experience in the Advantage AF trial, because as you can see, more than 50% of the operators used only the initial bolus of 3 milligrams of nitroglycerin. Other tips and tricks for using the PFA. If you have, for example, in this case, a left atrium that is not very dilated, and after the PV applications, you have a narrow corridor. What I personally do is to close the corridor by doing just 2 to 4 applications more in the roof to prevent roof-dependent atrial flutters in the future. Other tips and tricks: you can avoid the severe bradycardia during the left PV applications by giving atropine. This is what I personally do. I give atropine between 0.5 or 1 milligram before the applications. Or you can use a quadripolar catheter in the ventricle to pace the ventricle. A third option is to wait for the rhythm to recover. It's just some seconds of bradycardia or asystole, no big issue. When doing the posterior wall, the usual way to do it is to do 2 applications in each location, and for each location there must be some overlap, around 0.5 centimeter, 1 centimeter overlap between locations. The carina now is very easy to see with the 3D mapping integration. It's very easy to see the size of the carina. And for big carinas, when there is a big gap between applications between the 2 veins, ipsilateral veins, what I do is to give extra applications in the carina to avoid re-entries around the vein. For common trunks, segmental applications in the common trunk will do the job. Usually, but if you do CT before your procedures and you know in advance the size of your veins, you can, in the case of the FARAWAVE at least, you can choose the 35 millimeters millimeter diameter for the FARAWAVE. And to prevent stroke, it's very important to maintain an ACT high, between 300, 350, and it's very important also a careful manipulation of the catheter. In summary, this is my last slide. PFA for atrial fibrillation ablation with single shot catheters is safer than thermal techniques. There is lower rate of cardiac tamponade, no esophageal injury, no persistent phrenic nerve palsy, less stroke. It is also a highly effective procedure with at least similar results at 1 year compared to thermal procedures. The posterior wall isolation with PFA single shot catheter, as shown in the Advantage AF trial, is a very simple and safe technique that can implement your PV isolation for the ablation of persistent AF. And the applicability in other locations needs awareness of the potential complications and needs further investigation regarding the benefit, of course. Thank you so much.
Thank you, Dr. Marta. That's a very interesting tips and tricks for the PFAs for AF. I have a question here. So in your practice, for all your index, paroxysmal, and persistent AF patients, specifically the persistent AF patients, do you think about the posterior wall straight away, or do you undertake more mapping to find out whether there's substrates or scars before you go ahead.
Yeah, good question. Thank you. Well, I have to say I do individual approach. I mean, not all persistent AFs are the same. Persistent AF, for example, that lasts more than 7 days, but it's just 2 episodes in a year, is not the same as months in AF or long-standing AF. So for the first case, for the first example I did, I do just PV isolation, especially if the left atrium is not severely dilated, it's a good size. I just do PVI without mapping. But for more persistent months or long-standing AF with a moderately dilated atriums, I go straight forward in the first procedure for PV isolation plus the posterior wall, because I believe in these cases probably PVI is not enough. This is my belief, although we don't have the proof for that.
Yeah.
But now with the PFA is so simple, and the result is so clear. It just, all the electrograms disappear in the posterior wall, that and the rate of complications is still low. So I don't have doubt to go for that in the first procedure.
Sure. Yeah, Dr. Siep.
Very nice presentation. I have one question regarding the complication. As you mentioned, there are 2 rare complications associated with PFA, such as acute coronary artery spasm, and the other one is acute hemolysis. Do you think the 2 rare complications, the instance is different between different PFA systems?
Well, the risk of hemolysis has been related to 2 things. First of all, well, the number of applications. We saw in a study that more than 70 applications is related to can be related to a significant hemolysis, although this is not translated into clinical outcomes in majority of the cases. And it's also related, the second factor that influences the hemolysis is the contact, as I mentioned. It's important to maintain always a good contact. Now with 3D mapping, it's very simple. What I do in my practice, for example, in this case, is that I go beyond PV isolation. I don't look into aptoglobin, or of course I look into the creatinine post-procedure, but what I do is to give some saline for prevention of renal failure. Some saline. Normally, these are patients with normal ejection fractions. So, 1/2 liter or 1 liter of saline during the stay in the hospital will prevent any big complication. I never had any complication actually related to hemolysis.
Thanks, Dr. Mata, and thanks, Dr. Siep, for your question. Let's, in the interest of time, let's push on to the third topic, and it's by Dr. Chen Wei Da.
Yeah. Okay. Thanks for your.
Let me have the slides.
Yeah. This is Wei Da Chen from Taiwan. So can you see my slide now?
Yes, we can see it, Dr. Chen.
Yeah. Let me. Okay. Yeah. It is my honor to stay here to make some presentation, and the talk about this issue is the hint after closure AF. because we know that the closure AF they make some presentation on the ACC in New Orleans maybe in I forget October. I think in October. Yes, and I think the result makes everybody a little bit shocked that in high risk bleeding risk patients of atrial fibrillation, if they put on LAAO in the patient, but the overall complication rate and bleeding risk and the stroke rate will be higher than medical care. So in this situation, because in our daily practice, we may suggest patient with a high bleeding risk that the patient should receive left atrial appendage occluder implantation rather than medical treatment. But the culture F that showed us the different results. So today I will show you some my personal opinion. Or most of the presentation is my personal opinion. There will be a little bit evidence, but I think most of the talk about this the next maybe 15 to 20 minutes will be my personal experience and personal opinion. And so let's talk about something about closure AF. And I think the most important that you should know the final version of closure AF is not published yet. What we only know is the presentation profile that they showed us in New Orleans in October. So the details about all the results, all the information that basically is still unknown yet. And the closure F is a multi-center randomized prospective trial, and it was conducted in Germany. And there were 42 sites enrolled in this study. And they basically enrolled the patients with two requirements. The first one is the patient should have a history of bleeding and anywhere bleeding. Only if the patient have a bleeding, they will think the patient is eligible for this study. And the second requirement is the patient should have a high HFrEF score, which means higher than 3 points of a HFrEF score. And they will separate the enrolled patient into two groups. The first one is they let the patient to receive the LAAO implantation, and they did not tell us that which kind of LAO they used or the distribution of the Watchman or emulate. We don't know yet, and we know that there will be from 2018 to 2024, there will be at least 2 or 3 versions of Watchman that we don't know which Watchman they use. And for emulate, that the previous version of emulate is a hard plug, but yeah, we don't know yet. We don't know that which emulate they used, and they separate the intervention methods into left atrial appendage occluder or best medical care. And what is best medical care is basically follow the physician in charge. His personal opinion. If the doctor in charge think DOAC is still the best policy for that patients, they will just use DOAC, or they will use other medications, and they did not specify what the other medication is. And they compare the outcome. The outcome include stroke, systemic embolism, cardiovascular or unexplained death, or major bleeding. So this is something about closure AF. And the study was started from 2018, and the last enrolled patient is about 1.5 years ago, so 2024 in April. And they enrolled about almost 900 patients, and they follow up the patient for 24 months, which means about 2 years. And so let's see the results. I think the results is only available data that we can get from the internet about culture AF, because they are not officially published yet. So we can only get this number, and this data, and this data is the only data that you can find on internet. And you can see that about the composite primary outcome in the left atrial appendage occluder group, the number is 60.83% in every 100 patient year. Yeah, and in the best medical care, the number is 13.27%. Every here is 100% patient year, and the p-value for non-inferiority to left atrial appendage is not achieved, and you can see the hazard ratio. Yes, the number is higher in the left atrial appendage occluder group, which means that in the patient with a history of bleeding or with a high HFrEF score, if you suggest patient to do left atrial appendage occluder, it actually will make the patient get worse outcome than best medical care. And the follow-up about the mean follow-up year is 3 years. Okay, so I think the question is, should we stop placing an LAO in high bleeding risk patients? I think this is a major question, because before closure AF, normally we will try to place an LAO in patients with high bleeding risk. But after closure AF, should we change our daily practice routine? Okay, so I think, in my opinion, I will have 2 or 3 major critiques about the closure AF. The first one is they enroll patient with high HFrEF score, but high HFrEF score patients did not mean that patient really get bleeding or really had a bleeding history. So, and also that in every patient with high HFrEF score, normally the patient will have a high HFrEF score. I think everybody should know that, because there are 3 common items in HFrEF and the HFrEF score system. So if you really has high HFrEF score, normally you will get a high HFrEF. But come back to our daily practice that if a patient has a high HFrEF score, of course he will have a high HFrEF score, but the patient did not have any bleeding history. Do we really get a patient, suggest patient to do LAO? No, I think the answer should be no. Normally, we will suggest patient to just go on, just try NOAC, just try DOAC. And once the DOAC induced induce the bleeding, then we will suggest patient to do LAO, right? It should be our daily practice. We will not suggest a patient with just a high HFrEF score to receive LAO. No worries, it should be like that. So let's to see the guideline. What guideline told us that in the 2023 ACC/AHA guideline suggests us that if a patient has a contraindication for OAC, which means the patient may got some history of bleeding after OAC, then you can suggest patient to do LAO, and this is a 2A indication. But if a patient just has a high bleeding risk, the ACC/AHA guideline did not specifically mention that what is a high bleeding risk, but everybody, I think most of us will use HFrEF as a tool to predict the bleeding risk. So in this situation, in this patient with a high bleeding risk, if you suggest patient do LAO, the indication is only 2B, not so suggestive of LAO. So I think this suggestion pretty much comparable with our daily practice, that we will suggest patient to do LAO only if he has a bleeding, rather than just has a high bleeding risk. Okay, so our daily practice should be like this. If you have a contraindication for DOAC, we will suggest patient to do LAO. If you just has a high risk for DOAC, we will still suggest DOAC again. If the patient got some problem after the use of DOAC, we will suggest him to do LAO. But we don't know that how many patients in closure AF is with just only high bleeding risk, rather than history of bleeding. So we don't know yet it. So maybe we all have to wait for the final publication of closure AF. Then we know the distribution of the enrolled patient. We will have some more information, and we will have more direction to try to think if we need to modify our routine to care the patients. Okay, and the second critique is about the high event rate. I don't know why that the closure AF has a higher event rate than other studies. That the closure AF using you can see that they enroll patients and the follow up of about 3 years, and the event rate is quite high. In LAO group, the number is 16.8. And in medical care group, the number is about 13.3. So the number is higher than the similar study that Prague 17. Prague 17, they enrolled about 400 patients and 200 patients in LAO group and 200 patients in the medical care group. In the patient number will be about half of the closure AF. But you can see the event rate. In the first year, the event rate will be about 10% in the LAO group and about 11% in medical care group. And after they follow up for patients for 4 years, the number going down from 10 to 6 and from 12 to 7. So I don't know why the closure AF patients significantly have higher event rate, and I'm not sure the reason. And I think maybe at least part of the issue is about the learning curve, about LAO implementation, because the study enrolled patient, the first patient enrolled in 2018, and at that time, the LAO may just come to the market, and many physicians may not know how to implement the LAO very detailed or very with high technique. So I think it's a must that patient at that very early phase will have a higher complication rate, and I think maybe this is the reason why the event rate will be higher in the closure AF trial. And then we can see another trial that emulate IDE. And this trial, they just compare emulate and watchman. They did not compare medical care group. So we don't know that we will not have a number about medical care, but we can just focus on the device group. In the first year, the emulate IDE, no matter you use emulate or you use watchman, the event rate will be about 60%. Yes, the number is similar as the closure AF, but just in the first year. And as a trend like Prague 17, that if you follow up patient for longer, the event rate will become lower. So after 3 years, the number becomes from 16 to about 9%. And in about 5 years, the number go further down to 8%. So yeah, once again, I don't know why the event rate is higher in closure AF. And I think the number higher may be partly explain why they get the result that LAO is worse than medical care. But I think, yes, once again, the real reason should depend on the final publication of this the trial. Then we can know more data. We can have some more explanation about this issue. And you can see that if we look into the Prague 17, and the bleeding rate about the LAO and the medical treatment, you can see the two lines actually attached to each other. So you think you can find that the bleeding rate is quite similar between LAO group and the medical care group. However, if you separate from procedure bleeding to separate out from the total bleeding group, you can see the non-procedure related bleeding, the number of LAO is significantly lower than the medical treatment group, which means the overall bleeding, although the overall bleeding rate is similar in the device group and in the medical group, but the most of the bleeding is happened during a procedure itself. And if you have no bleeding during the procedure itself, you will have a better bleeding profile after the long-term follow-up. This phenomenon can explain why the bleeding, the event rate going down from first year to 4 year, because the you only encounter the procedure-related breathing at a procedure itself at that time, and after that, you should the patient should have a lower breathing risk. So this is the what the PROG 17 told us, and you can see this the 4-year follow-up of PROG 17. The breathing here is the non-procedure related breathing. The blue line is the LAO group and is significantly lower than the red line, the medical treatment group. So I still believe that LAO should be with the lower breathing risk than medical care. At least you don't have to use DOAC again after you put down LAO. If there is no leakage or device-related thrombus, you don't have to use DOAC again. Then patients should be with lower breathing risk, and I don't know why the closure AF told us that the breathing risk is not reduced after LAO. And I think the procedure itself may be the reason for the bleeding, but yeah, we have to wait for the final publication. And about the emulate IDE trial that it told us, no matter for emulate or Watchman, you have about 3 to 5% that patient will get some complication during procedure, and most of the complication is bleeding, either for tamponade, pericardial bleeding, or the vascular bleeding. Anyway, the patient will get some bleeding complication during the procedure, and the number is about 3 or 4%. And so if you reduce the 3 or 4% from the procedure, I think the bleeding risk will be not that high from the LAO. And as our experience get more and more, and we know how to implement the LAO very safe, as our learning curve already become mature LAO implanter, the complication rate should be going down. So in my opinion, I will still believe that LAO should be at least a good alternative to NOAC, even for the patient with a contraindication to NOAC. Okay, and so we still need to wait for the final publication of the closure AF to explain why they got a high event rate in other trial, and we still also need to know the complication rate of the complication procedure related bleeding in the overall enrolled patients. The more procedure-related bleeding in the enrolled patients, the more easy to explain why they got a high event rate and worse outcome in the LAO group. Okay, so once again, let's come back to the question again. Should we stop placing LAO in high bleeding risk patients? Should we follow the suggestion of a closure AF? I think my personal current answer is still the same, that if a patient has some contraindication for DOAC, such as bleeding or drug allergy, or even they cannot afford the drug, I will still do LAO implantation for that kind of patients. And for patient who is just with a high bleeding risk, say that the patient has a head maybe 5 points or 6 points, they're very high bleeding risk, but he has any bleeding history, I will still go on NOAC treatment. And unless the patient really got bleeding from NOAC treatment, then I will suggest LAO implantation. Okay, so thanks for your attention, and this is what I talk, and I expecting your questions. Thank you.
Yeah, thanks, Dr. Chen. Thanks for your in-depth analysis of the closure AF, which took a surprising turn in terms of the outcomes. Let's hear from any questions from our panel or attendees.
I have one comment to this closure AF trial. I think the major problem of this closure AF is about the inclusion criteria. There are 2 inclusion criteria. One is a high a history of bleeding, and the other one is the high head bleeding score. But we don't know the proportion of these 2 inclusion criteria. Although we know the new ESC guideline recommended we cannot use high HFrEF score to stop NOAC. So this study is against the new ESC guideline. So
Yeah.
I think it's a major problem. So how do we think, Wei-Da Chen?
Yeah, I agree with that. I mean, when you face a patient with a high HFrEF score, you will think directly. You will think, yeah, I have to put a patient on NOAC, right? But if you try to calculate the head normally the patient will also has a high head score. But we will not stop NOAC because of a high head score. So yeah, I totally agree with the ESC guideline that we should not avoid NOAC in patient just has high head goal. I don't think it's reasonable. Yeah.
Thank you.
Yeah.
Yeah. So I think, well, I mean, together with the advent of PFA for AF as well, I think people are advocating doing PFA, PVIs, and closures at the same time.
Yeah.
So what do you think about the topic? I think it's a little bit different from what this topic is about, but any comments?
Yeah. I personally also do some procedure for some cases that I do PFA or cryoballoon ablation for AFib, and after that I will do LAO at the same time. But for PFA, I think there will be an issue that normally after PFA, we will notice the ridge between left superior pulmonary vein and LAO will become swelling. And after that swelling, it will make the LAO a little bit difficult because you have to insert the LAO device into the atrial appendage. And if the swelling is too severe, you will have some problem that put the LAO inside the AA. And also there is a problem that if you put the LAO into less swelled left atrial appendage, and you think the device is fixed very stably, and you will not dislodge, and you stop you just leave the LA in that. But after maybe 1 or 2 days, the swelling become better. The deswelling, will the LAO become dislodged or not? Yeah, yeah. I personally has one complication in this situation that I put the LAO after PFA, and in 2 days later, the LAO just dislodged, become a device embolization, and I have to take it out with our catheter. It's a very dangerous procedure. So
I have one more question.
Yeah.
For Wei-Da Chen. If
Yeah.
patient have AF under hemodialysis, it's
Yeah.
really contraindication to NOAC. How do you think this patient for LAO?
Yeah, I will just suggest them to do LAO. But
Thank you.
yeah, I would just say that I think you should receive LAO. But yeah, in hemodialysis patients, they always have some their personal experience and personal opinion, and most of the time they will reject my suggestion. But for me, I will suggest them to do LAO. Yeah.
Thank you.
Okay.
Thanks.
Okay.
Yeah.
Now we move the next speech. Dear all experts and the audience online, I'm the Dr. Minxiong Xie from Wanfang Hospital, Taipei Medical University, Taipei, Taiwan. It's my great honor to chair the following presentation. The next speaker is Dr. Kenny Tang from Singapore, the co-chairperson. Now he is the consultant cardiologist and the cardiac electrophysiologist in Teng Tong Hospital. He is also the university clinical tutor Yong Lu Lin School of Medicine, National University of Singapore. Today, he will give us the talk entitled Conduction System Pacing for Heart Failure with Reduced Ejection Fraction, Comparison with Cardiac with Synchronization Therapy. Let's give warm welcome to Dr. Kenny.
Thank you, Dr. Chair. Just let me share my slides. So, can you see my slides?
Yes. Please.
Yep. So the title of my talk is Conduction System Pacing for HFrEF patient, and comparison with the biventricular conventional way of CRT. So I have no disclosures. So I guess we all know that electrical dysynchrony causes mechanical interventricular and LV dysynchrony, leading to negative LV remodeling and poor cardiac function. And I think we have many landmark studies which have shown clinical, echocardiographic, and functional benefits, particularly in those with left bundle branch block and wide QRS. We all know that the biventricular pacing CRT actually corrects by the delayed LV electrical activation through pacing, and it's done through a branch of the coronary sinus with an epicardial LV stimulation vector activation wavefront, as well as a endocardial RV lead, either a pacing or defibrillator lead. Well, we do remember some of our landmark studies, specifically looking into HFrEF, less than 40% EF, and wider than 120 or 130 QRS duration, depending on which studies. So the initial, more severe NYHA3 patients, we know that about 60 to 70% of the sinus rhythm left bundle branch block are being enrolled in Companion and Miracle, as well as the HF as well, where they only receive CRTPs. In the RUF study, we look at a bit less symptomatic patients, NYHA 2, 3 and above. It's also studying 70% left bundle branch block patients, as well as this group of permanent AF patients are receiving AV node ablation. Moving ahead, and we have that big MEDIT CRT that analyzed 1 to NYHA, as well as a reverse that looks into this group of less symptomatic patients. We remember it's on top of the optimal medical therapy, we get about 20 to 40% risk reduction in all class. And of course, if you are more symptomatic, you're gonna get less hospitalization for heart failure, as well as more improvement in LVEF, together with all your functional status, as well as your echocardiographic parameters like your LV ejection ESV index, as well as the severity of MR, together with NYHA symptoms. Even less severe symptomatic patients get improvement. And MEDIT CRT actually focus most benefit in those with QRS more than 150 milliseconds, with equivalent benefits between the ischemic and the non-ischemics. Well, then again, with all this data, we do know that with all the sub-analysis, as well as a couple of meta-analysis as well, example, this one by Cunnington in BMJ, looking at all the important trials, including only those non-left bundle branch block ones, specifically the right bundle branch block and the IVCD populations. There's not much benefit to be seen as compared to the left bundle branch block ones. And then during the intra-op wise, if we do not see a good coronary venous system, lack or tortuosity in the branches, or if let's say the phrenic nerve captures at a very low LV lead, LV stimulation output, then we are very limited in terms of how we deliver the CRT. Well, as on follow-up, we all know that sometimes we get elevated thresholds from incipient MIs or scars, or depends on the substrate itself, or exit blocks, as well as some of the macro dislodgements. And even if we optimize, I think that up to about 1/3 in the literature after CRT optimizations, still not getting the clinical response. And could it be because that non-physiological depolarization and repolarization wavefronts from the epicardial CS veins? Then we usher in the era of conduction system pacing, and I think we started with the His bundle pacing, and then subsequently move on to left bundle branch area pacing, which is LVBAP. Could they actually be better than our conventional biventricular pacing? So it started off with His bundle pacing in the bradycardic AV block chronic RV pacing patients, whereby this study by Rahman actually showing that those patients with anticipated high RV pacing burden, more than 40%, his bundle pacing reduced death, as well as the hospitalization for heart failure and pacing-induced cardiomyopathy. Then there's this schematic by Ting et al. In the Journal of Electrocardiology, actually postulating that we can actually re-recruit the disease longitudinally dissociated fibers in the His bundle, even if the patient has underlying bundle branch block, with higher outputs overcoming the functional blocks. So these are the two small randomized studies initially evaluating the role of His bundle pacing. So both patients, both groups actually recruit those with LVEF less than 35%, left bundle branch block patients, and both the His CRT being strategies that are performed in this study demonstrate improvements in LVEF, QRS duration, and NYHA class, further consolidating what we understand in terms of the dissociation of bundles in the His being able to be overcome. Well, these two studies didn't show any superiority to the conventional biventricular pacing. And notably, there is actually quite a significant crossover, nearly half the patients crossing over from His to BiV in His sync. And if we look at the His alternative study, there's actually only about 70% success rate. So perhaps reflecting the inability of the His bundle to correct the distal left bundle branch block or IVCD. Also consistent with other studies, I think the implantation at 1 millisecond duration, it's an average of 2.2 volts, and at 6 months it stays there without coming down. So there has been a greater role of left bundle branch area pacing or LBBAP since Dr. Huang published in the paper of this feasibility of performing in a non-ischemic cardiomyopathy using left bundle branch area pacing. And he actually showed that at 6 months, 12 months, these patients actually have very, very low pacing threshold has been stable with the benefit of narrowing the intrinsic QRS from 168 milliseconds to 170 milliseconds. So thereby shifting the paradigm and the strategy to LBBAP. So we have a myriad of studies comparing the LBBAP versus biventricular pacing studies in HFrEF. And we do know based on all these studies, this LBBAP actually show lowered symptoms, lesser symptoms, shortened QRS duration, better echocardiographic parameters, and improvement in LVEF, both in the left bundle branch block patients as well as the non-LBBB patients. Recently there is a study that shows it reduced AF and VTs as well with the negative remodeling. So this particular study by Vijayaraman, 325 patients actually showed that they recruited non-LBBB patients at 46%. And also LBBAP has been studied as a viable option in those who failed biventricular CRT due to challenging CS anatomy. So, and I mean, well, I think intuitively we understand that a lot of these studies also mirror what our own experience as the reduced procedural and fluoroscopic times, as well as lesser complications because the absence of the need to cannulate the difficult CS. Well, I mean, we need to be mindful that LBBAP so far has been predominantly non-randomized studies and with increasing size in registry only data. So I think specifically, I think we want to look into some of these studies through the years. In 2021, I think Vijayaraman actually started this LBBAP collaborative study group. Fairly higher success rate of 85%, and like previously said, actually recruited the non-left bundle branch block patients half. And it actually shows very good outcomes. response in both left bundle branch block as well as the non-left bundle branch block patients. There is also a super response rate of 31%, and it's been shown more in the non-ischemic patients as well as the left bundle branch block patients, quite similar to what we saw in the Danish as well as our previous biventricular CRT studies. So that this is the proof of concept that even in the right bundle branch block patients, it's possible to narrow the QRS and correct the right bundle branch block if you undertake a left bundle branch area pacing with left bundle branch area capture together with possible programming to get the anodal capture to capture the RV septal side. The QRS didn't narrow as much, possibly due to the fact that I think about 50% of the study group of patients could only get the anodal capture, with a threshold of more than 3 volts. So I think it's unlikely that we will program at such a high output to drain the battery energy. So I guess that might be the reason why QRS is not narrowed, but LVEF actually improved significantly together with other clinical response. So this is actually the first RCT for non-ischemics as well, left bundle branch block patients by Yao et al. It actually shows that it's a very small study, and it actually shows a significant treatment effect of improvement in LVEF 21% versus 15% when they compared the left bundle branch pacing versus the biventricular pacing. Bear in mind that this is a 6-month follow-up and it's a very small study. So it might be confounded by some of the issues with the numbers, power of the study. And then subsequently, Juan Carlos Diaz actually published this paper studying the feasibility of using left bundle area pacing as a first-line implant strategy rather than a rescue therapy. And he actually recruited those patients who are indicated for the conventional kind of biventricular CRT indications and excluded those who previously failed CRT attempt. So the primary outcome is a combination of clinical outcomes as well as echocardiographic outcomes. And it's a much bigger trial with 300 over patients being recruited. This is non-randomized. Bear in mind, this is just a multi-center non-randomized observational prospective study. And it actually shows that the procedure done is significantly shorter, comparing both index LVBAP versus index by V pacing. The results is also significantly pointing towards better outcomes in terms of composite of all-cause mortality as well as the heart failure-related hospitalization, with a risk reduction of 30%, mainly driven by heart failure hospitalization. And when they actually look at subgroup analysis with those who have durable left bundle area pacing, meaning to say the left bundle is still captured rather than losing the capture and become an LVSP or a deep septal pacing. Those with durable left bundle area captured pacing actually do much better than the BIV group. Well, in the interest of time, I'll just skip a few slides. So the LVBAP and biventricular studies not only show benefits in those with reduced EF less than 40%. Recently, there is this study by, again, by the iClass group, also showing that this is with much larger numbers, and also showing that those with actually less than EF of 50%, including those with reduced EF patients, also benefiting from left bundle area pacing in terms of shortened QRS duration, all-cause, and heart failure hospitalization. The complications in the LVBAP is much lower than the BIV group. So is this the end of our conventional BIV pacing? Maybe not, because we do understand that some of this proximal left bundle branch area pacing or even the HIS pacing is inherently limited in the ability to restore physiological activation of the lateral wall if the patient have more advanced disease or distal conduction disease. So we have some of this data by Dr. Tong's group, Chicago, showing this intracardiac delineation of the septal conduction in the left bundle branch block area, and showing that it's only 50 to 60% have a true left bundle branch block in patients with conduction delay. So with that, we also know that conventional bi-V pacing has potentially a desynchronizing effect with non-physiological wavefront. So how about combining both left bundle branch area pacing and the bi-V pacing to address some of the limitations of both techniques and combining the pros? So essentially, there is a LOT CRT data as well. LOT CRT is actually a combination of using bi-V CRT as well as a left bundle branch area pacing. And it all depends on whether you need an ICD lead as well. So if you do not need ICD lead, it's a CRTP. And the RV is actually, the RV port is actually connected to the left bundle branch area pacing, while the LV port is connected to your CS lead. If it's ICD needed, then you will need a DF1 can and capping the additional pace sense of the DF1 lead or the ICD, using the pace sense port to actually connect to the left bundle branch area lead. And it's been shown that the LOT CRT is successful in 81%, and it produced more shortening in the QRS duration, together with much better improvement in the LVEF as well as the echo parameters of the LV volumes. So this is what I got from Europace, showing us how we would to tackle the type of device depending on the underlying rhythm, as well as the need for CSP versus biventricular pacing. So bear in mind, if you want to do a CSP CRT, be it left bundle branch area pacing or HIS pacing, you will require a IS1 connector port. If you have a CRTD in mind, then you plug it to the IS1 LV, which is bipolar, and then you plug it to RV if it's a CRTP. If you have a perm AF, you can choose to just plug into your RA with a backup in the RV, or you need an ICD. So it might be a dual chamber ICD in that sense. If it's a LOT CRT, you need an IS4 for the LV port, and then for the CS lead, and IS1 for all your CSP. Like previously mentioned, you might need a DF1 can. So recently, there's also this safety and feasibility of a left bundle branch area defibrillator lead, which combines the use of CSP as well as a defibrillation. It's still in the safety feasibility and this phase, and this is a leader LVBAP trial, which shows 98% successful DFT at first induction with very stable lead parameters for pacing. And so I think in the interest of time, I just quickly go through one of the study patients that we actually recruit for Ascend, which is one of our for Abbott for LBB-AD lead. So atypical left bundle branch area, left bundle branch block with a QRS of 178. EF was very low at 20%. So we embark on the CSP lead first, and then we advance the ICD lead into the left bundle branch area. Managed to narrow it 143, but it's not enough, not good enough. We decided for LOT because of likely distal left bundle branch area disease. And then we have a successful LOT CRT with 3 leads being plugged in. The EF actually improved with a pace QRS duration of 123 milliseconds. Could do short runs and jogs. So there are many ongoing future larger RCTs for CSP versus biventricular pacing. I think every one of us are very familiar with this 2023 guideline for cardiac physiological pacing for the mitigation of heart failure. By and large, it's still biventricular pacing, but I think the alternative of using CSP is increasing. And especially if you fail to establish CRT because of anatomy reasons, you could choose to perform LBBAP or HIS. So the take-home message is biventricular pacing in HFrEF and left bundle branch block patients are backed by robust data, but not in the non-left bundle branch block patients. And CSP actually has been shown to have better ECG, echo, and clinical outcomes. Shorter durations for fluoroscopic and procedure time, and is technically simpler with more stable parameters. HIS bundle has been ditched because it's difficult. Well, I think there might be a role to combine the benefits of both in distal conduction system. And we need to individualize our approach with armamentarium of this pacing techniques. So we look forward to future larger studies in terms of RCTs to inform us, and we look forward to all the different new pacing defibrillator tools as well. So thanks for your attention.
Thank you, Dr. Tang, for your very nice presentation. And I have a question for you. The first question is, we know the HIS bundle patient has a problem of a high threshold. If we did not consider this problem, do you think HIS bundle patient is more effective than LBB area patient for patient with heart rate and LBB? How do you think?
Yeah, that's a very interesting question, because the thing is, we all know that HIS bundle pacing, HIS area pacing is definitely more physiological than left bundle branch area pacing. In fact, there are actually some small studies, physiological studies, to show that hemodynamics-wise, the HIS pacing is much better than left bundle area pacing. But in terms of clinical outcomes, I don't have any answer to that. We all know that the pure left bundle branch block patients, if you are high up below AV node infranodal, I guess we can try and correct using HIS. But if, let's say, the blocks are much lower than that, I think HIS has a problem in the long run, having patients have developing more distal diseases. And then subsequently, we might need to think about upgrades again, or even a new CS lead. So I think that is the concern, other than the more difficult technical challenges.
Clinical practice. If patient with heart rate and the left bundle branch block, do you choose CRT or left bundle area pacing for him? If the patient with heart rate and right bundle branch block, how do you choose the device?
Sorry, so you're saying that for patients with HFrEF with left bundle or right bundle? Sorry, I can't hear.
Heart rate and the left bundle branch blocker, do you choose CRT or left bundle area pacing? If patient with heart rate and the right bundle branch block, do you choose CRT or left bundle area pacing?
Yeah, so if it's purely for heart failure patients HFrEF, and if the QRS is really broad, maybe 150 and above, I think for left bundle branch area block patients, I think we still consider the traditional biventricular pacing. So if we actually use a CS to try with CS together with a ICD lead and try and narrow the QRS, and if we don't, we might consider trying to narrow it further with locked CRT. But right bundle branch block area block patients, interestingly, some of the sub-analysis by MEDIT CRT does show that there's even worsened outcomes with right bundle branch block. However, with right bundle branch block, very broad QRS, you are not sure whether inherently they have concomitant left bundle branch block or delay as well. So those patients might actually benefit from CS. I think there's no wrong in trying left bundle branch area pacing for the right bundle branch block once, and see whether we can correct the right bundle branch block and the broad QRS. If not, I guess we can also lot as well. But I think the strategy for right bundle branch block is definitely more interesting than the left bundle branch block ones.
Thank you. Then we will move the last speech. The last speaker is Dr. John Ray Matis from Philippines. Now he is the chairman of Department of Medicine, Gusen Medical Center. He's also the research head of Department of Medicine, Premier Medical Center, Cabanatuan City, Musi, Philippines. He will give us the speech entitled Leadless Pacemaker in Symptomatic Sinus Dysfunction and the AB Block. When, who, and how. Let's give warm welcome to Dr. Ray Matis, please.
Thank you, Dr. She. I just share my slide. Sorry. Okay. Okay. Good afternoon, everyone. I'm Dr. Jerome Ray Machas. I'm a EP, practicing EP in Cabanatuan City, Philippines. I'll be discussing more on, there's so much interesting subjects a while ago. Thank you, first and foremost, to AP for inviting me here. I'll be discussing about leadless pacemaker in some symptomatic sinus node dysfunction and AV block. Then some tips, maybe when, who, and how do we use this armamentarium. Just a disclaimer, I came from the Philippines, so this is a low volume. Such things are lesser volume as compared to what we are fond of doing now, of narrowing the QRS through conduction system pacing. However, I promise to give you some takeaways about leadless pacemakers. So just I have no disclosures. For this lecture, we will be discussing about the clinical problem, the evidence of leadless pacemakers, indication, patient selection, technical considerations, and limitation and challenges. So just showing you the history of cardiac pacing in terms of form. So interesting enough that in 1950s, we have these large pacemakers. And it's even tethered to an extension cord. And in 1950s, it's already battery powered and sensorized. Only in 1958, when it becomes already implantable pacemaker. However, it's still big. I saw those pacemakers in the previous ESC. And in 2015, these are the modern pacemakers that we are already using at this point. Just some technological changes. And revolutionary was in 2016 when they developed this leadless pacemaker. Well, as far as I can remember, I'm already hearing about these leadless pacemakers as early as 2015. The entire device is placed within cardiac chambers without leads, without pocket. The rationale for doing these leadless systems are, first, of course, there is no lead. There is no lead to deal with. Okay, so you get away with complications. There's also no pocket because you will put it transvenous, usually femoral approach. There is no chest carrying. For those who are concerned with aesthetics, no arm movement restrictions post-implant, and of course, reduced infection risk. These are the currently available leadless systems worldwide. It's just two from Abbott, Medtronic. Medtronic was the first one to introduce this through their Micra. They're doing it with AV now, Micra AV, wherein it's a VDD system. It detects atrial mechanical contraction through accelerometry. That's the Micra AV. And for Abbott, they launched previously the Avir VR, which is just a single chamber leadless pacemaker. But now, just recently, maybe about 2 to 3 years ago, they launched a dual chamber leadless pacemaker system. So as you can see, this one is a smaller one. This system is called a VIR-DR. This is a smaller one for the atrial and the bigger one for the ventricular pacing. So this leadless system in the Philippines, sadly, it's only the Micra which is available, Micra AV. But I talked to the distributors of Abbott that they plan already to release probably next year. So we can have experience as well. So the diseases that we are dealing with in terms of bradycardia is first sinus node dysfunction, also known as sick sinus syndrome, which are the common presentations of sinus bradycardia, sinoatrial block, bradytachy syndrome, chronotropic incompetence. Just some review on the recommendation of the recent 2021 guidelines on pacing. What's important in sinus node dysfunction is you associate it with symptoms. When you manage to associate it with the symptoms of the patient, then you need to place a pacemaker. So a class 1 recommendation pacemaker pacing is indicated in sinus node dysfunction when symptoms can clearly attribute to the brady. Pacing is indicated in symptomatic patients with bradycardia, tachycardia also as a form of sinus node dysfunction in order to correct bradyarrhythmias and enable pharmacologic treatment. But most of our colleagues resort to ablating the atrial tachyarrhythmia. That's also okay if they prefer to. In patients who present with chronotropic incompetence also, so and have clear symptoms associated with it, pacemaker is indicated. Now, there's no question about atrioventricular block, second degree type 2 and third degree AV block or complete heart block is a standard indication for a pacemaker. So, review also of the guidelines is that class 1 recommendation is pacing is indicated in patients with sinus rhythm with permanent or paroxysmal third or second degree type 2 infranodal 2:1 or high degree AV block irrespective of symptoms. Now, for patients with atrial arrhythmia, mainly AF and permanent or paroxysmal third or high degree AV block, irrespective of symptoms, whether the patient is symptomatic or not, it's a class 1 recommendation to pace. Pacing should also be considered in patients with second degree type 1 when kebak that causes symptoms or is found to be located intra or infrahis if you do an electrophysiologic study. So in patients with AV block, a class 2 recommendation also, DDD should be preferred over single chamber to avoid pacemaker syndrome. We know that. And there is a recommendation also that for patients with marked first degree AV block, which a PR interval greater than 3.3 seconds, pacemaker should be considered a class 2A recommendation. And just showing you the gist of what I said. This is a diagram showing you the optimal pacing mode and algorithm selection in sinus node dysfunction and atrioventricular block. Our default option, you all know that you do in sinus node dysfunction, you put up a dual chamber pacemaker. It's just a sinus node dysfunction and persistent. With or without chronotropic incompetence, you always use the intrinsic ventricular activity of the patient, okay, through prolonging the AV interval and some atrioventricular management that your device can handle. So for the AV block, so it's DDD, and for AF, since the atrium is no more not much contributory to the overall electrical activity of the patient, you can implant a VVIR. Okay, now here is a more interesting. So how about if there are any reasons to avoid two leads or there are significant comorbidity of the patient, then you have an option to place a single chamber AI, okay, for sinus node dysfunction. And if the sinus node dysfunction is just paroxysmal, very occasional, not to too rare, you can just implant VVI for such patients. Same with AV block, you can implant a VDD, VVI. Okay, so patients with significant comorbidities, these patients who are very frail, okay, these patients you may want or you may consider implanting just a single chamber pacemaker. So what are the evidences of implanting a leadless pacemaker? When it comes to safety and efficacy, there are already a myriad of trials dealing with MICRA and AVEIR. The MICRA IDE trial, wherein they found out that there's low complication rates, high implant success on such patients. Now, MICRA post-approval registry, fewer complication versus transvenous. Marvel 2, they found out that the accelerometer-based AV synchrony is okay to use. Leadless 2, good pacing and sensing, safe for the AVEIR. And what's a technological advance in communicating leadless pacemaker is the I2I, which is used by the AVEIR DR. And it was studied by the I2I study, first in human dual chamber leadless communication. They also managed to compare leadless versus transvenous VVI, significantly fewer complications and infections, and the AV synchronous leadless pacing, which is used in MICRA AV through the accelerometer, is effective in selected patients. So what are the indications and clinical scenarios wherein you can use a leadless pacemaker? So as far as I know, you can use leadless pacemaker in symptomatic sinus node dysfunction, maybe those not requiring atrial pacing. Well, for us, because the AVEIR DR is not yet available, and those patients who require atrial pacing, whether you resort really if there's to a lead system. Permanent AF with slow ventricular response, high infection risk, such as those with end-stage renal disease, immunocompromised, prior device infection. Okay, so since you're transvenous, those with venous occlusion or limited access, these are the patients that may need leadless pacemaker. Now, post-TAVR, develop AV block. Since these patients are very elderly, frail, that's why in the first place you choose TAVR. Okay, those leadless pacemaker can be placed on such patients needing pocket-free and who wants cosmetically favorable solution. Leadless pacemaker is a good option. So according to the ESC guidelines since 2021, it's a class 2A recommendation that leadless pacemaker should be considered as an alternative to transvenous pacemaker when no upper extremity venous access exists or when the risk of device pocket infection is particularly high, such as previous infection or patients on hemodialysis. So in patients with hemodialysis, undergoing hemodialysis through AV fistula, sometimes it's a problem. Aside from that, the risk of infection is also high on them. A class 2B recommendation is it may be considered as an alternative to standard single lead ventricular pacing, taking into consideration the life expectancy on your patient. So when leadless pacemaker is superior, probably to transvenous, when you have a history of pocket infection and recurrent infection or erosion, you may point to leadless pacemaker. On uninterrupted anticoagulation can be considered also. Those patients who are very high CHA2DS2-VASc score, those patients who are really need this anticoagulation. Those frail elderly needing early ambulation, but that's not much of a problem since it's only on the limb, and those chronic kidney disease patients are undergoing hemodialysis. Okay, just some contraindication, or you can use leadless pacemaker with caution, is that if there is a need for significant atrial pacing, specifically those patients with chronotropic incompetence. So this is in red because right now, the advent of the Avir DR, wherein you can implant a dual leadless chamber pacemaker. So this might not be an issue anymore. Cases requiring CRT or CSP, at this point in time, there's still no data on using it as CSP. Okay, so very young patients with long lifetime device needs is also a caution. Although, again, in the advent of the Avir DR, you can already retrieve this leadless pacemaker. And those patients with mechanical tricuspid valve never had experience implanting with such patients. So those patients with sinus node dysfunction, now with paroxysmal SND, SND with significant comorbidities, and such patients with AV block, high grade where AV synchrony is acceptable through micro AV, post-TAVR, and those elderly frail where complications from transvenous system must be minimized. So against special populations that you should consider, hemodialysis patients or those patients with, this is important because there's a lot of cancer patients here with central venous catheters. You may opt leadless pacemakers and patients with recurrent device infections. So just some pre-procedure check. Well, check the patient before implanting pacemaker or planning a leadless pacemaker. Check this RV size, position, anticoagulation, and then you choose whichever is available, of course, and which is suited for the patient, and then the implantation steps. So it is also important to mind that the femoral venous access of such transvenous system or transfemoral system are very large bore. It's 23 to 27 French size sheath. So it's really big. Okay, so RV septal deployment preferred, tine versus helix fixation. The tine is being used by the micra, and the helix is being used by Avir. Then your threshold testing, the positioning is needed. Okay, then always check if you have complications. So I got this one, just some short video from for micra. These are the things that you will be needing. Of course, guide wire needle, introducer dilator, and micra delivery system. So first and foremost, you identify the puncture site. I think my opinion is you use a guided puncture, like ultrasound guided, to check for the caliber of the vein that you will be puncturing, and maybe check the course of the vein. So at this time, showed you that they will be inserting already. They have inserted so this is the delivery system of the micra. For micra, the lead is fixed in the delivery system. Okay, later on, the other video will be showing you that the lead can be removed or can be tested with the Avir system. So, and there are some knobs that you need to memorize when using micra. We're in deploy. This is the deploy knob. You lock the tether. And this video is very nice, showing you how the tine is fixing in the trabecula of the RV. What we preferred is mid to lower septum. You avoid in implanting it the apical aspect or anterior of the RV. You may have problems like tamponade and perforation on such sites. So this time you check the electricals and then reposition as needed, because at this time you're still tethered to the delivery system, and only when you are satisfied then you cut, and then you're finished. Okay, now
The invasive placement.
the second, sorry. So the second video will now show you about the device implantation of Avir system. So let's go straight.
Management. Oh, rhythm management. Wow.
So, okay, so it's also a delivery system. So the only difference is that the Avir system is a screw type, a helix type, and then you screw it in. Okay, and so you can also, at this time, you're testing, you can test if the position is good. Okay, you can check for several positions, no? And then you afterwards you untethered this lead, and then you put. Now you have an option. Yeah, you now have the option to put up an atrial lead in the right atrial appendage using the atrial leadless pacemaker through this, and same process continues. Okay, so aside from implanting for micro AV system, so we optimize the AV synchrony. We can use echo-guided optimization. We check and it is important for patient selection. Those patients with sinus rhythm preserve mechanical atrial function for this to totally be successful AV synchrony device. So follow-up strategy, remote monitoring. However, sadly, this is not available in the Philippines. So we do it manually. The battery longevity is up to 17 years in newer models. And for end-of-life options, for Micra, there's no option to retrieve it. You just abandon it and implant other Micra if ever you run out of battery. For Avir, you have a retrieval system. For Avir, you can retrieve it through a retrieval system. So implanting additional devices sequentially, you can do that. Just some limitations and challenges is that for us, there's no atrial pacing for the Micra AV and AR. You just sense the atrial mechanical contraction. The AV synchrony is dependent on activity level and motion. Extraction challenges for Micra. Yeah, so you better leave it if there are no contraindication. So no current cardiac resynchronization option yet. However, there are research ongoing. So the last slide, leadless pacing is safe, durable, and ideal for selected patients. It is best suited for VVI, pacing, permanent slow AF, infection risk, and venous access issues. AV synchrony is possible with proper candidate selection and optimization. And the future is exciting for this leadless pacing. And with that, thank you so much.
Thank you for your very nice presentation. I have one question for you. For patients with AV blocker, need a high ventricular pacing rate. So, what kind of patient you choose CSP, and what kind of patient you choose leadless pacemaker for patient with AV block?
For those patients, you mean Dr. Shea, for those patients who need a high ventricular rate, is it?
AV block, so the patient
For
need
those
a
patients
high,
with AV block.
yes, so
Okay,
high
for those
ventricular
patients
pacing.
with AV block, my first option personally is to put up a conduction system pacing, mainly a left bundle branch area pacing, because like I've said, we're really now fond of narrowing those QRS, and we really need those that ventricular synchrony, especially those patients that discussed by Dr. Tan, those patients with reduced ejection fraction. There's no option yet for leadless pacing for those.
Thank you. Any question from Dr. Tan?
Yeah, now in your area of practice, is it still just the BVI Avir, or you guys are getting dual chambers as well?
We just get this Micra AV, Dr. Tan. And I still don't have experience. However, I plan to. We We have the VR, just a BVI in practice. Yeah.
How about Dr. Sia?
The
Because I foresee that there's gonna be these two implants coming into your market, and how are you gonna choose between the two of them? What's your considerations between the two?
In Taiwan,
The two systems, yeah.
the DR or
in Taiwan, the atrial leadless is not available in Taiwan right now. Maybe in the next year, maybe. So if the patient need battery sensing, we put the micro AV. Thank you. Because time limit, I have to close this section. First, I would like to thank all the speakers who give us the comprehensive and the excellent presentation, and to share their great experience in AF screening, AF ablation using pulse field ablation, stroke prevention effect of LAO, conduction system patient in HFrEF, and the leadless pacemaker in bradycardia patient. Of course, we need to thank the Asian Pacific Society of Cardiology Cloud Forum, support the online important symposium, technological innovation in cardiac arrhythmia therapy. Finally, I would like to thank Professor Junli Lin, the current president of Asian Pacific Society of Cardiology, for organizing this excellent symposium and invite all the experts to give us the wonderful meeting. Professor Lin, would you like to say something?
A very good session covering almost. Yes, this is an interesting section actually covering all the fields of the coronary interventions. I think it's a great section, and thanks to both interesting section.
Okay, hope to see you soon. Bye-bye.
Yes. Bye-bye. See you all.
Bye.
Okay, see you.
Yeah, thank you. Bye.
Thank you. Thank you all. Bye-bye.
Bye.